Welcome to Fertility Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining.
Hi, everyone. Hello, everyone. Welcome back to Fertility Village. We are here in March, and it is Endometriosis Awareness Month. And we know many of you in our community, 1 in 10 of you, are impacted by this disease.
So that's why we're so excited to be welcoming Dr. Geoff Zeni today. Dr. Zeni is a gynecologic surgeon at Markham Stouffville Hospital who specializes in fertility-sparing surgery. He was also my surgeon and performed the laparoscopy that made it possible for me to have a successful embryo transfer after several failed attempts. So thank you so much for joining us, Dr. Zeni.
Thank you very much. Caley, you probably give me a little too much credit. You know,
No.
There's a big fertility team that was part of it. It wasn't just me. So
it's true. I had a great
part, but yeah.
She had a great team.
Right off the bat.
Yeah. Could you give us a little background, give us an intro of your specializations and sort of what drove you to want to specialize in fertility-sparing surgery?
So sure. I started, I did, I don't know, how far back do you guys want me to go? I was born in Georgetown. I grew up in small town Ontario.
Give us the whole story.
I ended up doing my medical school in Australia, in the University of Sydney. And interestingly, that my gynecologic supervisor in medical school was George Condis, who is like the godfather of endometriosis mapping ultrasound worldwide. So it was my intro there in terms of like what the possibilities were. Then I came back to Canada and I did my residency in obstetrics and gynecology at the University of Toronto, followed by a fellowship in advanced minimally invasive gynecologic surgery. It's a bit of a mouthful, which essentially is like complex benign gynecologic surgery that I did at McMaster University. And that was 2 years after I finished my residency. And then I started working in Markham. And it's funny, I didn't really expect to become a fertility surgeon. I'm going to be very honest. I kind of got pushed into it by Mavis Garcia and Crystal Chan and Marta, because and they're like, oh, we have patients. You need to see these people. We think you can help them. And I was like, okay. So I just kind of fell into the fertility component of it. My fellowship was, I'd say the vast majority of my fellowship was endometriosis surgery, complex endometriosis surgery, and complex fibroid surgery, all of which is laparoscopic. And then, some Mullerian anomalies like uterine septums and things like that. But I didn't expect that fertility was going to become my niche until I kind of had to make it my niche per se. So there was a bit of learning on the job, because there was a lot of things that I thought I knew through fellowship that when I got into practice, I was like, I need to know some more about this, especially in the fertility realm. And I did a lot of, reading and education kind of closer to the end of my my fellowship and into my kind of early training. So that's kind of how I turned into the kind of the fertility surgeon role. And I love it. And it's been a huge passion of mine ever since I got into it, because there's a huge unmet need. And I didn't realize that unmet need was even there until I kind of got into it. So I love it. The patient population is absolutely fantastic. These are people who need somebody who can explain things and talk to them about options and, be able to treat different things that are impacting their fertility in a kind of surgical way. So I love it. It's great. It's fantastic.
That's and me. Clearly you do a good job, because it helped Caley for sure.
Yeah. The surgeries are long sometimes, but they're worth it. And I guess outside of that, I'm a dad, I'm a husband, I have 2 young boys. They're insane. And a lot of that comes into kind of where I come from. We didn't struggle with infertility, but I can't even imagine it being so stressful for us just getting pregnant when we didn't have trouble, right? It's hard to imagine how hard that is as a travel for people who, they have the initial stress of thinking about kids and all this other stuff, and then it's hard, and it's not working, and it's years, and it's money, and it's ups and downs, and huge emotional roller coaster. It takes a huge toll on people. So we can make that easier. That's kind of the goal we have.
That's fantastic. I love that. Let's talk about endometriosis. Can you give us a little description of what it is, maybe some of the primary symptoms, and is there any less obvious symptoms that people should look out for? Because we know it can be really difficult to diagnose.
Yeah. So endometriosis in its kind of most basic form, when we think of it as a definition, when people who are born with the uterus, they have a period. They start menstruating, they shed the endometrial lining. This is the lining on the inside of the uterus. This is probably like a lot of information that your viewers already have, because they're probably quite already well educated in the fertility realm. So the endometrium is that lining that the embryo is supposed to implant into. During implantation, that's what it sticks to and starts to develop the placental attachment. Endometriosis is tissue that's very, very similar in microscopic appearance and in reaction and to hormonal stimulus to the endometrium, but it's located somewhere that's not inside the uterus. So typically, for the vast majority of patients, it's located solely within the pelvis, but this is tissue that's not really supposed to be there. 10% of people who are born with the uterus end up having endometriosis. In the fertility world, people with unexplained infertility, 50% of them are going to have endometriosis. That's like a huge number of people who have like quote unquote unexplained infertility. And nothing has come up in all their fertility testing that has showed them exactly why they're not able to get pregnant. So it's very impactful on people who have infertility, but there's lots of people who have endometriosis and have no problems getting pregnant. So there is this kind of dichotomy that just because you have endometriosis does not mean that you're going to have difficulty getting pregnant. When it comes down to it on kind of a functional molecular level, sorry if you guys hear my two kids just losing their mind in the background. They're like 2 floors away.
We can't hear anything.
Okay, perfect. Thank God. So if you're thinking about it, like on a functional level, as you cycle through the menstrual cycle, there's increases in estrogen and progesterone, and endometriosis typically reacts to estrogen. So when estrogen goes up, the endometriosis becomes more active. Just before the period starts, with that big drop of progesterone, you get activation in terms of the endometriosis lesions, and they release a whole bunch of inflammatory factors. And historically, we were thinking about this as a pain disease, right? So people who have endometriosis, we talk about their pain. Unfortunately, the amount of pain people have is really not correlated to the amount of disease at all. It's not correlated even really to the type of disease, which is kind of infuriating for a lot of people because they have no symptoms at all. Yeah. Their first symptom sometimes is infertility, and they have no pain. They don't have bowel problems. They don't have bladder problems. They don't have pain with their periods.
Is that the silent endometriosis?
Yeah, this is what people kind of call silent endometriosis. And sometimes people find this. My colleagues call me into the operating room because they're like, we're just doing this hysterectomy on this 65-year-old person who has like endometrial cancer, and we can't even find her uterus because all the adhesions are so horrible with that pelvis. So sometimes people just don't know. Part of this is, I think, that people have normalized, unfortunately, pelvic pain. And people who do have symptoms think their pain with their periods is very normal, right? So all this inflammation that happens with their period, they're like, oh, well, my mom said my period's bad. Other people told me, doctors have just told me that, I got to deal with it. It's just period pain. Periods aren't supposed to be painful. It's like the
just in general, they're not supposed to be painful at all.
In general, they're not supposed to be painful. If you have to take more than an Advil or a Tylenol, that's not a normal period, right?
Oh man, I think
that's news to a lot of people.
I know, and this is like what drives me absolutely insane, because I'm like, people are like, oh yeah, like my periods aren't that bad. I only have to take like a day off work. I was like, what are you talking about? It's not that bad. Like, if I had to take a day off work every month because I had pelvic pain, that's insanity. And, like, the amount of impact it has on your like job progression, your life, your quality of life, all these things are huge impacts, and people don't even think about it. They're like, oh, it's just period pain, but it's not just period pain. Like, periods are not supposed to be painful. They're not supposed to be debilitating. They're not supposed to impact your quality of life. That's a hard conversation with people sometimes because they're like, what? And it's like, I'm like, yeah.
It's downplayed so much from like adolescence. So yeah, they don't know, right? So that's why we're here. That's why Oasis is here. We're teaching people to advocate for these things and having lives with specialists like you on to help educate the masses that pain during your period is not normal. So thank you for helping us with that for sure, because it's definitely a big conversation we have regularly monthly at our support meetings.
Yeah, it's a bit of a wild ride for me when I have these conversations. And I think my patients who know me and have been in my clinic multiple times, they're like, yeah, we know, right? Like, they come to this realization after our first appointment when I talk to them about this, and they're like, oh yeah, so I talked to some of my friends and like their periods are fine. I'm like, yeah, I know their periods are normal. Periods are not normal, right? But I don't know. It's my soapbox I'll die on, I think, probably. So in general, there's 3 types of pelvic endometriosis. Endometriosis can be located anywhere in the body, although kind of extra pelvic. So endometriosis outside of the pelvis is extremely uncommon unless you have extremely extensive pelvic disease. So inside the pelvis, 3 types. There's superficial, deep, and ovarian. Ovarian is essentially ovarian cysts that have old blood in them, because just like the endometrial lining bleeds and sheds, same thing happens inside the ovary, but it's stuck inside the ovary itself. So the blood builds up inside that ovary and creates kind of this blood-filled cyst. And this is what people call chocolate cysts or endometriomas. And the reason they call it chocolate cysts is because when you break them open, all the fluid comes out. It looks like molten Lindt chocolate. Kind of gross. But I'm like very used to it, so I'm like, I think the things, and then I see your faces, and I'm like, oh yeah, it's not normal. But it's because it's like all this old blood that's essentially been shed and bled into these ovaries over time, and it gets partially digested, so it turns brown, just like iron rusts. Okay. The superficial endometriosis is, if you can think of the entire abdomen being covered in cellophane. Okay, so all the abdominal structures, the organs, and then all of the lining of the abdomen is covered in like this cellophane called peritoneum. It's very, very thin, and you can imagine somebody's taken a Sharpie and just kind of drawn dots on it, or have kind of poked holes in it and drawn dots as, like, you know, as you can stretch it and you poke holes deeper, or draw dots deeper, and that's superficial. It's not invading into any of the tissues underneath, and you know, that's the most typical and most common type of endometriosis that we see. And then there's deep endometriosis, and deep endometriosis used to be called DIE, but it stood for die, and that was a really bad acronym, so we don't use that anymore. We call it DE, which is just deep endometriosis. Instead of deep endometriosis, much better. And that is essentially endometriosis inside a structure. So it's either invaded or it was seated inside of a structure, most typically the ligaments that support the back of the cervix, but in other places, including, you know, in the bowel wall, in the bladder wall, you know, in the areas around the tubes between the kidneys and the bladder. And this causes nodules, so like inflammatory nodules, kind of like scar, but it's really painful and attached. Some people have a lot of pain with intercourse, especially in certain positions, because in certain positions, somebody's hitting these nodules that are really close to the back of the vagina. So they get a lot of really bad discomfort associated with intercourse sometimes. That's the general thing. Like, you know, we see endometriosis on diaphragms and in lungs, and people have had it in the brain and all these other places. But those cases are extremely rare. We check in surgery. We like take pictures of the diaphragms every time to check what the liver and the stomach and all the bowel and everything else like that, and the appendix and all that stuff is just, that's part of our normal survey. And we look at all those things at the beginning just to make sure there's not something that's missed, and make sure that when we do take it at the endometriosis, we take it all out.
Amazing.
Did I miss something?
You mentioned pain during intercourse, pain in general. What other symptoms? Is there anything else people should be looking for generally? I know like migraine was mentioned to me at some point. I don't remember if it was by you, whether that's connected.
So you can get hormonal type migraines. So people can get what they call menstrual migraines, which is due to a shift in the progesterone closer to the end of the cycle. So people start getting migraines before their periods start. That's not associated with endometriosis, but that is associated with like a vascular phenomenon that happens in the brain as a result of shifting hormones. But in general, the most common pain symptoms that we see are pain in the days leading up to the period, and for the first few days of the period that starts to get better as kind of the period goes on a little bit. And that pain can be very debilitating, or could not be that severe in some people's eyes, right? It's really variable. People can have pain with bowel movements during their period. They can have blood in their stool before their period starts and during their period. They can have pain with urination, or pain with the whole bladder, or pain after they urinate. And sometimes blood inside the urine associated with it as well. These are kind of the common symptoms we talk about, other than pain with intercourse. The really frustrating part of this is you can have a lot of really extensive disease and no pain. You can have like 2 small superficial lesions and lots of pain, and everything in between. And the correlation between the number of lesions and the amount of pain doesn't match, which is, I think, hard to conceptually put together for a lot of people, because they're like, well, I have a lot of pain, I must have a lot of endometriosis, or I have no pain, or it can't be that bad. And really, those things aren't necessarily true. Some people have really bad endo and horrible pain. Some people have very little endo and no pain. But, you can't predict how much endo is there based off of the amount of pain people have, right? Which is hard. And that's where, proper investigations, endometriosis mapping, all this stuff comes in.
We do want to talk about that.
That's coming up.
Yes. But first, I want to mention something that you said when I first met you. You said, "I'm so sorry you're dealing with this." And that was like no one who I had spoken to almost, well, Dr. Garcia did, but very few people I dealt with spoke to me in that way and were like, this sucks. And you acknowledged how shitty it was. Can you talk about, like, how did you find that empathy for your patients? Because it is so rare amongst, doctors that we're dealing with in the fertility world. And like, do you have any advice for doctors in terms of that kind of bedside manner?
I guess, like, be a little bit more human, right? Yeah. I see patients, I try and put myself in their shoes. Now, this kind of, the whole thought of like how to empathize with patients really kind of clicked for me during one of my residency interviews. So I was interviewing at the University of McMaster for obstetrics and gynecology residency. And I don't know how many of your viewers will know how like the residency interviews go, but it's an absolutely absurd way of choosing people for medical specialties. But that's like grapes, but that's fine. Essentially, McMaster was like, you had a whole bunch of 12-minute sessions with a whole bunch of different groups. And you walk around this hallway and go into each of these different rooms, and you have to do a different task or answer different questions with different panels of different people. And one of the groups was a group of 3 residents. Okay, so these people like 4th year residency, they're closer to their end, and they're like evaluating who's going to be a good resident, who they would work with, I guess. And at the end of that session with them, they're like, okay, so as a male, how are you going to be able to empathize with somebody who is having pain with contractions? And I was like, how absurd of a question is that? Okay, like, obviously, I have no idea what it's like. But I also have no idea what it's like when somebody has a heart attack. And it doesn't mean I can't empathize with them. The whole idea of empathy is that you can try and put yourself in somebody else's shoes, imagine what they're going through, and like try and help them through what they're going through. And I remember being like so shocked by that question. What in God's name are these people talking about? Like, how is this like a legitimate question? Isn't this so obvious? And I thought it was a little bit sexist at the time, and I was a little bit offended, but I'll try and keep my personal opinions of that question kind of to myself. And it led me down a journey in terms of, is this actually all that rare in terms of physicians? This is something you really need to screen for in terms of figuring out how can somebody empathize with something they don't understand. I think most of these obstetrics and gynecology residents have not had babies before. they don't know what contractions are like either, right? Even if you are female. And me being a male, I don't think that I'm going to downplay somebody's contraction pain. I'm also not going to downplay somebody's period pain because I've never had a period. And like a normal, non-painful period, having to bleed every month sounds bad enough to me that like I can't really fathom the idea of both pain and bleeding every month, and that just sounds absolutely miserable. This is why I don't have to have a period, because I would have given up a long time ago. I would have given up everything. I can't deal with this. But so to me, I'm like, this sounds horrible. And then people who deal with this pain, deal with fertility struggles. I think we talked on that a little bit at the beginning, but it's been really kind of the thing that I keep in my mind. And my mother had really horrible endometriosis, really horrible pain. She ended up having surgery when I was young. I was like young, like impressionably young, like I think maybe like 5. And I don't really remember all that much about it, except for my dad being like, "You gotta go easy on your mom. She's having a rough time," right? Like, and now that I talk to my mother about these things, now I'm in the field, it's so mind blowing for me in terms of it explains so many things when I was growing up. All these things that were just kind of put under the rug. My parents' fertility troubles, all this other things that people had, and people just didn't talk about it. And these are horrible experiences that people have to go through and live with. And I think if you don't acknowledge that, and you don't even like accept that people have had a hard time, just that's a complete disservice to your relationship. The relationship I plan on having, my goal with every person is to be able to build a safe space in the clinic. And the first understanding of a safe space is that I need people to be able to open up to me. I need people to trust me. I need people to understand that we're not going to be judging their answers. And part of that is trying to put myself in somebody else's shoes. So if I can't do that, there's never going to be a kind of truly safe relationship that we have in the office. And if we don't have a safe relationship, I'm not going to get down to the meat of what actually matters, which is the patient's values and goals. And if we don't, like, I can be like, "Oh, you have endometriosis, let's take it out." But if the patient's like, "My endometriosis doesn't bother me. I'm doing everything I need to do," I'm like, why would I put you through surgery with potential risks when that's not part of your value system? So if you look at somebody as a disease, you come with all these ideas of how to treat it. But if you actually understand the person and what their goals are, then you can treat the person and kind of help them match those goals and get to kind of where they want to get to. And if you don't talk to people about these things, you'll never know.
That's fantastic.
You got to empathize with them, or else you're like dead in the water before you start.
That's amazing. That's an amazing perspective to have in this field. And as Caley said, we don't always see it. So I know Caley's grateful, and I know other patients are incredibly grateful to have that compassion, because again, it can be a lonely road. So to feel seen and understood it really does mean the world to a fertility patient, for sure.
Yeah, it may feel obvious to you, but it truly isn't obvious to everyone in the field. We have support groups where we talk about these things a lot.
Yeah, absolutely. So that's awesome. I'm going to move on to our next question. So is it true that it can take up to 10 years to get an endometriosis diagnosis? And can you explain how that diagnosis is ultimately made?
It can take a lot longer than 10 years.
Well,
when you think about a lot of the patients I see, right? How do you classify 10 years? Do you classify 10 years as like the first time they went to somebody and said, "My periods are really painful," or "I can't get pregnant," and then how long it is until they get their diagnosis? Or is that 10 years from their onset of symptoms? And I would say the vast majority of patients are more than 10 years from their onset of symptoms, because either it takes them a long time, nobody takes them seriously as a teenager, because a lot of the time these symptoms are onset in a teenager. People are like teenagers, their periods, and come on. Like, they're in high school, missing days at school. Like, how do you not take this seriously? But people don't take it seriously, unfortunately. So a lot of the time when I'm seeing people who are 20 and I'm telling them they have endo, they're like, "Well, now I can go back to university. I can actually study." And I'm like, how were you guys doing this beforehand? But so from onset of symptoms, I'd say most people. Wow. From onset of like actually looking for help, the average in Canada is about 8 years, which is way too
That's
long,
crazy.
right? It's insanity. And historically, people were diagnosed in one of two ways. They were diagnosed based off their symptoms and based off physical exam findings, which we know are unreliable for the reasons we just talked about. And the other way they would diagnose people is with a laparoscopy, so a surgery. So you do a surgery for a diagnosis, which in my mind is like, how do you do a surgery if you don't know what you're doing? You should not be going in blind to anything ever. So how we diagnose it, how I diagnose it with the team of people I work with at Care Imaging in Markham, is we do it with ultrasound. And there's really, really good evidence that's been developed over time. We kind of touched on this earlier, but the ultrasound diagnosis of endometriosis. In terms of being able to diagnose deep endometriosis and ovarian endometriosis, our sensitivity and our specificity are over 90%. That means like that's a really good diagnostic test. You know, when we're talking about diagnostic tests, the COVID test people were doing were like way lower than that.
Yeah.
So in terms of a diagnostic test that people will trust, like that is like, I can see it on ultrasound. I'm like, you haven't, there's nothing else looks like this on ultrasound. Not only do you have endo, but we can tell you exactly where it is. And then superficial endometriosis, the sensitivity is not as good, but that's mainly based off of the fact that if there's fluid inside the back of the pelvis, that fluid really allows for a window for us to be able to see those lesions. And if there's no fluid there, the fluid is normal, depending on what time in the cycle it is. But if there's no fluid, there's the two organs are kind of on top of each other, and we can't see that interface. So we can't see a lot of those lesions, which makes it a lot harder. So that means our sensitivity for superficial endometriosis is lower. And there's ways we can go about trying to improve that. One is to actually put fluid into the back of the pelvis and like through the uterus and the tubes. That's super uncomfortable. So if we don't have to do that, I like to not do that because I think torturing patients unnecessarily is just kind of a bad idea. If you need to do a test and it's uncomfortable, that's fine. But I think that's probably experienced sonohystogram. It's not a fun time. And essentially it's a sonogram, right? So if we can avoid doing that, we give you a diagnosis without doing that, we do. And then the other ways we wait and come back later at a different time of your cycle. The problem is the access to the ultrasounds is really hard. So being able to time it at specific times in the cycle is difficult. And then, so in terms of the diagnostic laparoscopy, we don't really do it. I don't really do it. You know, we do it in very specific circumstances. But in general, we know that those patients have no deep endometriosis, no ovarian endometriosis. The most they're going to have in the pelvis is superficial endometriosis, and I counsel them very well in terms of the risks, in terms of what risks there are with the surgery, and you know what risk benefit, and kind of balancing that, and the patient ultimately gets to decide. But the ultrasound diagnosis means that the more we improve access to these ultrasounds, the better things are going to get. Now, here's the other issue. A normal pelvic ultrasound does not aren't looking in the places.
He paused, or me?
Oh, am I paused?
Oh, we're good now. I think we're coming back.
Very briefly paused.
So a normal pelvic ultrasound will not pick up most endometriosis. Won't pick up deep endometriosis, for sure. Won't pick up superficial endometriosis. Might pick up ovarian endometriosis because it's a lot more obvious.
But the mapping will.
But the mapping will pick up those things. But it's a very specific ultrasound done by people who are very specifically trained. And until we, like in Markham, we're training more techs, right? So we're training more sonographers who are able to perform these ultrasounds and able to find these things. They know where to look. Nobody, you know, I talked to Kirby and Katrina, the two ultrasound techs I work with a lot. And when I started training them, they're like, we didn't even know you could see these things. Like, we didn't even know these structures were going to be visible on ultrasound. Like the uterus sacral ligaments, the torus, which is the space between the uterus sacral ligaments. And these ligaments are the ones that support the back of the cervix. This is the most common place for us to find deep endometriosis. And they're like, we didn't even know you'd be able to see these. I showed them fallopian tubes that were normal. And they're like, no, you can't see a fallopian tube that's normal on ultrasound. You can only see it with the foot. I was like, look at this. You can see like the end of the tube just like flapping in the wind, right? Inside these. And they're like, this is crazy because these are things that are just not taught.
Right.
And this is why general pelvic ultrasound don't see these things. It's really frustrating for me because I get these really bad reports from general ultrasound places. And I'm like, this doesn't tell me anything, right? I can't take somebody to the OR based off of this. We need to do proper mapping so I can have a proper consent process before we ever take somebody to the operating room. Because if you don't know what you're getting into and you don't know what those risks are going to be, like, we shouldn't be doing the surgery.
Right. Someone actually asked, and you sort of answered this, but whether like the mapping could miss stage 3 or 4 if it was superficial.
So by definition, stage 3 or 4 have more than just superficial.
Okay.
Can I go on a tangent here for a second?
Yes.
Go for it.
This is another hill I'll probably die on. I think the stages when they were made were clinically important. I think the stages.
I remember this tangent.
I know. I've had this tangent with my patients because people are like, "What stage am I?" And I'm like, "I don't care what stage you are." And it's not that I don't care that you don't have endometriosis. It's not that I don't care where your endometriosis is. Not that I don't care how much is there and what it's impacting. Those are the things I actually care about. The number that's assigned to it is based off of like an old school staging system that looked at what surgical complication rates should be based on surgical complexity. But it was a surgical staging system. So you had to do the surgery to stage them. I'm like, well, then what the point is that? Because you can't counsel the patient after they're already asleep.
Right.
So shouldn't you be able to tell the patients where all of their lesions are and how those lesions specifically will adjust their risk of surgery? And that's exactly what we do with mapping, right? Well, you have a bowel lesion. You have the option to take it out or not. This is how big it is, based off of how big it is and where it's located. This is realistically what we would have to do to take it out. We could shave it. We could, do a disc resection. We could have to take out a whole segment of bowel. And all of those are very specific based off the size, the location, what they're attached to, all this other stuff, how thick they are through the wall of the bowel. And if you don't do this ultrasound, you're not going to know. Even when you're in laparoscopically looking at it, a lot of the time we can't tell. The ultrasound in a lot of ways is actually way better at being able to tell where all these lesions are than the actual surgery itself. And that's why people have surgery and they come back and they're like, I still have deep lesions. I'm like, yeah, because they didn't know your deep lesions were there and they just left them there.
Right.
That's actually one of our questions that was coming up, which is like, what is this surgery? What do you do? Is it, because we've heard about ablation versus excision.
I'm opinionated. I don't know how else.
The non-doctor version.
There
Burning
are
versus cutting.
general approaches to endometriosis. Approach number 1 is kind of I don't want to say old school because a lot of people still do this, right? The ablation. What ablation essentially is, they take a electric cautery device. So it's essentially a stick with like electricity running through it, and they electrocute these little bits and they burn them, right? And people use electric cautery in surgery all the time. This is like not something new. But they like burn these little lesions and they go through and they go zap, 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 zap. And they're like, okay, cool. And it's gone. And we're like, okay, first of all, no, it's not. Because when you burn a visible lesion, it's probably microscopic satellite lesions that are surrounding that visible lesion. So you're not burning those, the endo's still there, right? You just can't see it. And on all the structures that they're like worried about, like fallopian tubes, or on top of the tubes between the kidneys and the bladder, on top of the bladder itself, on top of the big blood vessels and nerves inside the pelvis, they just won't burn it because they'll be like, oh, well, we're going to burn the thing that's underneath. And fair, they will burn the thing that's underneath. So please don't burn it. But this is why it's really just not a very good surgical technique, in my opinion. And all advanced gynecologic endometriosis surgeons do excisional surgery. If you go and see somebody and they tell you that they do ablation, they're not an endosurgeon. And because endosurgeons don't do ablation. It's just like, it's the common practice, the gold standard practice to do excision. It means that you take out the visible lesions with a border of normal tissue, like we do for cancer surgery, right? So you're taking margins. And this means that around those microsatellite lesions are encompassed in what you're removing. And we separate the lining of the pelvis from the structures that you don't want to hurt, right? So when you take that lining out, you're not damaging those structures. So you don't have to worry about not being able to take out structures because they're on top of something bad or something worrisome. So you can take that stuff out. The problem is also deep endometriosis lesions a lot of the time look like a superficial lesion. So on the top, all you see is like the tip of the iceberg. You know, you have like endo lesions down here, and you got the little tip you see it poking out, and you just burn the top. You left all the endo underneath, right? So if you don't excise that deep lesion, you left the endometriosis still there.
That kind of moves into the question of, can it come back even when you excise it versus?
That's a hot topic. I will give you my personal opinion, which, to be fair, I do not think is it's becoming more and more popular in terms of the people who are endometriosis excisional surgeons. But it's not necessarily the norm. My opinion is it does not come back. My opinion is you're probably born with it. It progresses in your teens, 20s, and by 28 to 30, your progression probably stops. So what you're left with at that point is kind of what you have. The progression, so if you have surgery like when you're 18, and then you have more endo when you're 35, like there's probably things that were just missed because they were microscopic. Whoever operated can see them. But they were there and they were left over. Somebody has surgery when they're 35 and there's a bunch of endo left over. It's just because it wasn't taken out. And that's my personal opinion. It's not recurrence, right? It's not that people have like it come back. It's that it wasn't all gone, right? It's residual disease. That might
It's a really hot take, I feel like.
It's a little bit of a hot take. And like it might get me in trouble. And that's fine. I don't care. Like if people don't agree with me, they don't have to agree with me. But that's like my personal opinion. Is there a lot of medical evidence for that? No, because when you go back and like people are like, I took out all the visible disease, but then we go and scan them 6 months later and they have deep nodules that weren't taken out. I'm like, was it taken out? Is it still there? I'm like, I think it's still there. I don't think that this big nodule grew back in 6 months. Right. And people are like, well, I think it was all gone initially because my pain went away. And there's good evidence to say that sham surgery for endometriosis will actually make people's pain go away at the same rate as like endo surgery for 6 months to 2 years. So
it's like a placebo effect?
Yeah, it's like a weird placebo effect. But I don't think it's actually a placebo because these are like sham surgeries. So they like actually put the ports in, they fill the belly up with air, they did the full anesthetic. And I think that there's other things that impact people's pain. It impacts the nerves, it impacts the pelvic floor muscles. These are a lot of other things that contribute to people's pain with endometriosis. So if you calm all that stuff down because you give them a paralytic, which causes massive relaxation, and you give them huge doses of pain medication, which essentially obliterate all of the pain signals from these peripheral nerves, yeah, you'd expect that their pain is going to get better. But it comes back. And then they're like, well, endo came back. And I'm like, I don't think your endo was actually really gone. But I'm not the norm. Maybe I'll change my mind later in my career when I start operating on my patients again. And I'm like, I swear to God, it was gone and now it's back. But who knows? I'm not there yet.
That would be horrifying.
I wouldn't love that. And I'm going to have to change that hot take if that's the case. But until then, I'll rather die with that one.
Fair. In terms of fertility, people often are told, okay, you get your surgery and then you go on 3 months of Depolupron or something that's like a suppressant drug to suppress the endometriosis. Do you have a take on that? Because that's a pretty common recommendation that like I personally got, and a lot of people I know, they got that recommendation.
I don't really give that recommendation to fertility patients. So where that comes from is there's some medical evidence that says that if you put people on suppression post-surgery, they have a more durable, long-lasting pain improvement. With regards to the fertility evidence, There's not very good evidence for any of that. That being said, there's a whole bunch of different cycles that people try in terms of prior to either a stim cycle or prior to an embryo transfer that they'll put you on suppression, like Vizan or something else like that. Vizan's a medication. That's the brand name. The generic name is Dianogest. And it's a progestin medication, so it's like progesterone. It's really, really good at suppressing endometriosis. There's no estrogen in it. So it's really an endometriosis drug. And it works really well at suppressing endo. So people will put people on that beforehand to try and like decrease the inflammation inside the pelvis before they do fertility treatments. And, you know, the evidence is pretty wishy-washy.
Yeah, we have a question about that. If it's a superficial endo, does it always need to be excised, or could you just do suppression instead?
Oh, you can do whatever you want.
Would you recommend that?
It's just water, just as a heads up.
Sure.
Yeah, it's not booze, but
We're very cash here.
The questions aren't that hard. So, okay. The idea of doing surgery, the idea of doing suppression is not based on what I want to do. And there's not a right or a wrong answer. The answer is what is right for the patient. And I don't know that until I actually talk to the patient and figure out what their goals are, right? So it's hard for me to say, is, you know, suppression going to be better for you or surgery going to be better for you, because I don't know the person. And this is the whole idea of the consultation and getting to know a person and actually asking them what their goals are. Wild thought, I know. But if you don't ask them those goals, then how do you give a recommendation in terms of treatment? It isn't cancer, right? So it doesn't turn into cancer. It's not, you know, in certain circumstances, endometriosis can, you know, cause serious organ damage. And in those cases, yes, we're going to be recommending surgery. But in the vast majority of cases, it's not. So you want to leave it? You can leave it. In general, I talk about three main options. Do nothing option. Everybody gets that option, right? Some people want that option. They just wanted an answer, right? They're like, I have endometriosis. This explains a lot. I can deal with it with like naproxen, and I'll be just okay with that. I just needed my answer. That's fine. There's medical suppression, and there's like a whole bunch of options in terms of medical suppression. Problem with medical suppression is every single one of those options is going to make it so you can't get pregnant. So if your goal is pregnancy, the options are not the greatest for you, right? At least if your goal is immediate pregnancy, right? If your goal is pregnancy eventually, then maybe you can try this for a while. And a lot of those are really, really effective. Everything comes with side effects. Surgery comes with side effects too. Doing nothing comes with side effects, right? So when you talk about side effects, no side effects, you know, we have to talk about choosing the right thing for the right patient. And there's a whole bunch of different medications, and not all of them are going to be right for the right person. There's not a one size fits all. We don't put everybody on Dianogest. We don't put everybody on Lupron. Actually, in general, I don't use Lupron very often. But that being said, there's some patients who do very well on Lupron and love it. You don't hear that on the internet very often, but
No.
I can tell you some stuff.
I know. Don't worry, my patients tell me that. They're like, I want to go on Lupron. And I'm like, in general, I don't really talk about Lupron very much, because I think in general, there's so many other medications that we can use to treat people, unless they're really having breakthrough pain with all those other medications. That's really when Lupron comes into it for us. But, you know, Vizan or Dianogest is very good at shrinking the endometriomas, right? So if people are having mass effects from these endometriomas, they're pushing on different organs, that can help them without surgery. Then the last option is surgery, right? And surgery can be tailored as well. It's not exactly like picking off a menu, but, you know, we talk about the risks and benefits of different things. And people are like, well, I don't want the bowel lesion because I don't have any bowel lesions or bowel symptoms. And I'm like, totally fine. We can leave it there. Right? That decreases your risk of bowel injury by a lot. Right? Decreases your risk of waking up with an ileostomy bag and needing to, you know, have a bag that you poo in for 3 to 6 months, which, surprising, nobody wants. Right?
No.
I know. Why?
That's a hard pass. Yeah.
You know, some people are like, that's what I have to do. That's what I have to do because my bowel symptoms are so bad. Right? And that's fair. right? But this is where the informed consent comes in. This is when knowing what your patients want, asking them what they want, asking them what their goals, what their values are, really comes into it. I don't prescribe these things. I talk to people, have a conversation about what they want to do. I might make some recommendations, but that's usually based off of what I know their goals are already.
Mm-hmm.
So I can pretty safely assume everyone's goal here, pregnancy. Like for me, it was single-mindedly, I don't care about my pain. I don't care about any other effects. What's the best thing to do with my endometriosis to get pregnant as fast as possible?
As a general rule, first of all, there's a lot of people who have endometriosis who don't have infertility. And this is where the whole thing comes into it. It's like, you can have endo and you can get pregnant very easily. You can have endo and you do 3 IVF cycles, multiple transfers, a bunch of IUIs, and you don't get pregnant until after your surgery, right? You kind of know what I'm talking about.
Mm-hmm.
That is a really hard road to get there. But the question is, you're not going to know if you're infertile or have a struggle with fertility until you actually try. So you got to do some stuff first. As a general rule, IVF is going to have a much bigger impact in terms of your fertility and improving your fertility than an endometriosis surgery is going to have. Some people are really, really hesitant to do IVF for a whole bunch of different reasons, religious, personal,
financial.
Yeah, here it's really inexpensive. Yeah. So yeah, it's huge into it. Like people who don't have benefits, like even the drugs, even if they have a funded cycle, like drugs are so expensive. And like that's one cycle, never mind multiple. So yeah, there's a whole bunch of reasons people don't want to do different things. And surgery is an option, and surgery in Ontario is free, right? You don't have to pay for it or by the medical plans, right? So like our Ontario government health insurance plan, right? In the US, it's going to be a very different story in terms of how much things are going to cost. And IVF is going to be cheaper than your surgery in the US. So there's a balance here, but medication is not really a good option for people who are trying to get pregnant because all the medications stop you from getting pregnant. Okay. But surgery is not necessarily the first step. And as a general rule, people haven't done IVF and they have endo, I say you should do IVF. And if you get a normal embryo, you should transfer that normal embryo, because even with endometriosis, you have a much higher chance of getting pregnant than you do of not getting pregnant with that normal embryo. If that normal embryo doesn't stick, let's talk about surgery. Because at that point, we know we can move that needle. So like the needle starts here and then IVF brings it all the way to here. And then we might move it to like there by surgery. So we don't move the needle nearly as much, but that little bit might be just enough to be able to get the embryo to stick in terms of helping with implantation in pregnancy. So if I'm all for it, right? I love operating. I'd love to operate on everybody. It's just not right for everybody, right? So that has to be a personal conversation. That has to be like I think should be an in-depth consent discussion between a physician and a patient. And not every patient is going to be the same. So there's not going to be one size fits all.
That's fair. We have a couple little questions, I think. So you talked about how endo can shift. Can endo cause cysts on or around the ovaries, or can they look like cysts? Can endo look like that on?
So an endometrioma, so like a chocolate cyst, is a cyst inside the ovary.
Okay.
So it's cystic because it bleeds into the ovary every month. You can get cystic structures from endometriosis in other places. So like sometimes the endometriosis that invades into the bladder wall or invades into the back part of the vagina. We can see that either through a cystoscopy, which is a camera that goes into the bladder, and we can see like a little black dot at the top. And it's like a hemorrhagic cyst full of blood. And sometimes we see that in the vagina. It's like this little kind of purple area at the back of the vagina, and that's cystic. But in general, people talk about cysts, they're talking about the ovaries. They're talking about endometriomas. It's also frustrating because a lot of ultrasound people will be like, this could be an endometrioma or a hemorrhagic cyst. Two very different things. Also, not so much of a hot take, but they don't look the same. Okay. So the fact that everybody cops out and says, oh, it could be this or it could be that, they're wrong, right? Like it's one or the other. We just look at the images and know what you're looking at. And if you do, then you can tell me which one it is. It's very rare that I'm like, could be or couldn't be. And those are usually the really tiny ones because they're just too small for us to be able to determine which way. But there's a lot of different ways we can tell the difference. And it's frustrating when we see those reports.
Yeah.
I think
MRI mixes it up a little bit more because it's the signal of blood. So they can't tell if it's new or old. A hemorrhagic cyst is essentially you ovulated through the side of the ovary and through a blood vessel, and that blood vessel bled back into the follicle. So you have this enlarging follicle filled with new blood and clot. The new blood looks different than endometrioma blood.
Gotcha. That's super interesting. Oh my gosh. I think you're going to have a lot of people that are going to want questions from you. If someone like suspects they have endo and they want surgery because that's their goal, or they're not really sure, like how would you recommend them to advocate? How would you recommend them? Can they self-refer to a surgeon, or do they need to be referred through a regular physician, an OB physician?
So in Ontario, you cannot self-refer. I don't think in Canada, period, except for kind of in quasi parts of Quebec where they have kind of private healthcare for some physicians. But in general, it's covered by the provincial health insurance plan. So it falls within the Canadian Health Act. So it needs to be a referred service. Okay. So that doesn't need to be referred necessarily by a family doctor. It can be referred from a nurse practitioner, it can be referred from a family doctor, and can be referred from any other specialist, right? It doesn't have to be necessarily an OB. So I get referrals not too infrequently from urology colleagues of mine who find bladder endometriosis when they're looking at somebody who has bladder pain, and they look inside with a cystoscopy and they see the endometriosis lesions on cystoscopy, and they say, no, thank you. And then they send them to me, right? So I don't necessarily get all my referrals just from obstetricians or family doctors. That's the most common, right? Infertility specialists, so REIs or your fertility doctor, are obstetrics and gynecology trained and then did fellowship in fertility stuff typically. So they can refer to us. But you got to ask. And I'm going to be dead serious. You got to be a bit of a pain in the ass. A lot of the time, and because you got to push for it, because some people are like, oh no, first of all, they don't necessarily want the answer they're going to get because it might delay some fertility treatments. Whether that is going to be financially motivated or not, I will leave everybody up to decide. I think some fertility doctors that I work with, not so much work with, but are colleagues of mine, are a little bit more financially motivated. In terms of the people I work with on a regular basis, I know that their goals are the goals for the patient, right? Which is trying to get the patient pregnant if that's what they want. And those are the people I have closer relationships with in the fertility world, because we actually want the same thing. And those are the people who send patients to me a lot more often. Like, surprise nobody, right? Because they want the answer. And people don't typically have to push as hard to get that referral. But yeah, push. And like, be annoying. Be like, I want the referral. Just send the referral. And get them sent to somebody who knows what they're doing. Like, I'm by far not the only one. Okay. There's a lot of people out there in Canada and the US who are extremely good endometriosis surgeons, but you should go to an endometriosis surgeon if you think you have endometriosis.
What's the wait time like to get to see an endometriosis surgeon? And someone also asked to see you specifically, what would be the wait time?
Okay. So am I allowed to swear on this?
Yes.
Okay. It's dog shit. Okay. It's really bad. In general, they did a survey in Canada, Canadian kind of advanced gynecologic surgeons like myself, and the average wait time for surgery was between 1 and 5 years.
Wow.
Okay. That's
Any way to expedite that?
It's hard.
Mhm.
In some ways, things get expedited if people are willing to give up OR time for us to operate in their OR time. But OR time is really a precious commodity. So, people get bumped to the top of the list for a couple of reasons, right? If they have endometriosis, which is like essentially causing end organ damage, so their kidneys are dying, or they have a bowel obstruction because of endometriosis, then yes, we push them closer to the top of the line because it's organ dependent. But it's hard. It's hard. It's a really long wait list, and it sucks. And if I had a really short wait list, I would love it because my wait list stresses me out a lot. Right now, we're looking at like 18 months in general for time of like consultation to time of surgery. If they tell me at the consultation they want surgery, I usually will hold time for them based off of how long I think it'll take. And then after we do their advanced mapping ultrasound, then we can kind of tease that time down to a better idea. So then we can book our OR days. But yeah, it's a long wait. In terms of the wait time to see me, that depends on who sends you. Because sometimes I get some people who have we know that they have organ damage already, and so those things are bumped up a lot. But in general, it's a long wait. It's like 6 to 8 months.
So 6 to 8 months to see you, then another 18 to actually have that excision surgery.
Yeah, that's
wow.
Pretty bad, eh?
Yeah.
And the I have a lot of OR time, so my wait times are in general on the shorter side, because I operate a lot more than a lot of my colleagues. Because they can see lots of people in clinic if they're not operating that much, but then their wait times just get longer and longer and longer. Right.
I heard somewhere if you're flexible and you're on a cancellation list, that can help. If you're willing to just drop everything and go, sometimes it can be quick, but
yeah, if you're really nice to the admins, that's probably your best. Because most of us, we're not the ones who manage our wait list, right? I'll tell my admin, this person's actually very urgent, so we need to book them in sooner. But if I'm put this person on the wait list, my admin runs the wait list, right? And it's not like she's vindictive, because she's not. She's an absolutely delightful human being. But if you're really nice to them, and there's a cancellation, they're probably more likely to call you.
Fair enough.
And I think that's just human nature. In general, my admin works down the wait list, right? So she'll start at the next person who's in line who's not booked for surgery, and then she'll start offering them stuff. But if it's short notice and she's oh, I need somebody who's just gonna say yes, there's some people she knows who are just gonna say yes, right? And call them.
Fantastic.
So yeah, it's not really a cancellation list kind of thing, but it is you should make it known that you're I will take whatever time you're going to.
Fantastic.
If that's
I like that.
then you kind of stay in the back of the admin's mind. Yeah.
Right. Awesome. Well, we are pretty much out of time. We didn't get to everything, but if you guys have more questions, we'll email Dr. Zeni and get to them. But I think we got all the ones that have been asked. So thank you again, Dr. Zeni, for answering these questions, and again, being passionate and being an advocate for those of us in the fertility world. It really does mean a lot to us, because we don't always feel seen, but I know your patients feel seen. For sure. So some really great tips, some really great information, and we're very, very, very grateful for you being on with us tonight.
You really are.
Thank you so much, guys. Absolute pleasure. It's a great time.
Perfect.
And where can people find you online? Is there anywhere you want to plug for people to follow you?
I have an Instagram account that I think you guys link to. Sure, go for it. You can find me at my office.
Perfect.
Fair enough.
We will add that. This live will be uploaded onto our YouTube channel, onto our podcast, so you can listen to. We'll tag Dr. Zeni. We also want to say stay tuned. We're about to announce our winners of our draw for the night one that's coming up next weekend on March 24th. If you haven't already, it's supporting Fertility Friends Foundation and their grants that they offer to fertility patients. So it's going to be a fun night to party, not something we often can do in the fertility world. And also please mark in your calendars that our fertility party in support of Oasis Fertility Support Network is June 22nd at the King Edward Hotel in Toronto, and you can get your tickets at oasisfsn.com. So do not miss that. Okay, drum roll for our winner, who will be contacted through social media. Caley, do you want to read? Can you read that?
I was trying to read it, but Tom and Amanda Mark?
Yeah, I would say that's
All one
it.
word?
Tom and Amanda Mark is the winner of the 2 tickets for night one on March 24th for Fertility Friends Foundation. We're so excited for you. We'll be in touch, and we hope you have a great time. Again, thank you so much, Dr. Zeni. I'm sure you'll be seeing a lot of Oasis people very, very soon on your wait list.
Thank
And
you
a
guys.
reminder that support group is on Monday, guys. So we'll see you then.
Thanks for all you guys do.
Perfect.
Thank you so much,
Bye,
Dr. Zeni.
everyone.
Bye.
Bye.